Good morning, folks. Welcome to Chapter 3, Part 1, dealing with quality and technology and medical malpractice. And when you talk about quality in healthcare, it's a little bit difficult to define. You can't define quality in healthcare the same as you would as defining quality in products of the Apple Store or your favorite car dealer. There's a lot more that goes into quality control in this field. Quality, technology, medical malpractice may seem like a odd mishmash of topics, but all three share a theme: to make medicine better. So this chapter is going to aim to familiarize yourselves with major initiatives to measure and improve healthcare quality, but also to emphasize what a difficult task that really is. So again, how do you define quality? It's not the easiest thing to do. Improving the quality of healthcare in the U.S. seems to be one thing that all parties, whether they're patients, providers, private companies, and government, can agree on. However, as in many other areas of healthcare, it's been proven much tougher to actually apply than do. First problem shows up is defining what quality even is. Perhaps defining what quality is not is easier. So the Agency for Healthcare Research and Quality, or AHRQ, discusses healthcare quality failures in four categories, examples of each. So failure of healthcare quality would be something like underuse of services. For example, a third of Americans with heart disease receive the influenza vaccine, despite evidence that it significantly decreases the risk of heart attack, and that people with influenza are at a significant higher risk of heart attack. Overuse of services. Now, I think overuse of services would be a bad thing, but it actually is, because half of all patients diagnosed with the common cold are incorrectly diagnosed or prescribed antibiotics, which do nothing for the common cold and can actually contribute to poorer health outcomes by killing off good bacteria. We talk about the misuse of services. Up to 18% of hospital admissions may result in harm as a consequence of procedures, medications, hospital-acquired infections, and diagnostic procedures, as well as falls, many of which were either unnecessary or could have been prevented. Then you have variations of services. Medicare patients in Alabama, for example, are 8 times more likely to receive epidural steroid injections for low back pain, more than Medicare patients in Hawaii. So in contrast, the AHRQ defines quality as doing the right thing at the right time in the right way for the right person and getting the best possible results. This may seem pretty straightforward, but it's also vague. The real trouble is in measuring and quantifying and comparing quality in healthcare. The University of Michigan health researcher Avidis Donabedian took a stab at trying to develop a framework of quality in healthcare called the Donabedian Triad. It has 3 arms: structure, process, and outcome, and it's widely used in the healthcare industry. A summary of this triad can be seen here. Its first characteristic is develops with structure. How is it organized? It may be highly complex in a complex health system. It's probably the easiest to measure. Disadvantage is that it may fail to capture the quality of care by individual providers. Difficult to determine a gold standard. So it looks at things such as hospital size, human resources, supplies, and equipment. The next component would be process. And when we measure process, we're measuring or asking what was actually done for the patient. It's more easily measured and acted upon than outcomes. A problem with this, it's a proxy for outcomes. All may not agree on what's called a gold standard. So products of this guideline may be should be guidelines, protocols, patient's wait time. Last component of this triad would be outcome. And in outcome, we ask ourselves, what actually happened to the patient? This is what we really care about, right? This may take years to occur, may not reflect the quality of care, requires case mix adjustments to account for different patient populations. It tries to make provisions for morbidity, mortality, and health status itself. The debate about measuring and comparing healthcare quality has increasing importance because real money is at stake. As we've said many times in this course, healthcare is all about the dollars and cents in this country. Insurance companies, state and federal government programs are trying to pay for healthcare services to quality measurements, and many quality measurements for hospitals and other facilities are now posted online for patients to check out. This means a lot of focus on identifying correct quality measures and adjusting them appropriately for differences in patient populations and severity of illness. Some important definitions to cover when we talk about quality issues are things such as safety, which is basically the first part of the Hippocratic Oath, do no harm. Or as the AHRQ puts it, safety is the freedom from accidental, preventable injuries produced by medical care, as opposed to an adverse event, which is any harm that occurs to a patient because his or her medical care or stay in a healthcare institution. An adverse event may occur when a mistake has been made or when best practices, even when best practices were followed, but a bad outcome still resulted, like a patient having an allergic reaction to a medicine. One recent study found that adverse events occur during 1/3 of hospital admissions. Medical errors refer more specifically to preventable adverse events that occur due to errors during the delivery of care. Example would include a physician making an incorrect diagnosis, a nurse giving medication to the wrong patient, an IV pump failing during surgery, and a blood test not being ordered due to a miscommunication among hospital staff. So as far as patient safety goes, medical errors have been a major focus on improving healthcare quality for over the past 2 decades, especially after the article "To Err is Human: Building a Safer Health System" was published in 1999 by the Institute of Medicine. The report shed light on medical errors, suggesting that over 46,000 to almost 100,000 people died every year from preventable medical errors, far more than from Alzheimer's disease or drug overdose. This publication had a huge impact, initiating research about communication guidelines and information technology to prevent errors. The medical errors that loom largest in popular consciousness may be cases in which surgeons have operated on the wrong limb. However, these cases are rare. If anybody is familiar with the old Saturday night comedian and movie comedian Dana Carvey, had a cardiac bypass surgery back in the 90s, and they actually bypassed the wrong artery. That's just an example of an unacceptable medical error. But the most common medical errors aren't due to negligence. Rather, most errors occur because of deficiencies within the incredibly complex healthcare system. Think of a large hospital, fast-paced, stressful environment, thousands of employees, a dizzying array of computer systems and medical devices. It's easy to imagine how a small miscommunication or oversight can snowball and lead to an unintended event. Efforts to stem medical errors don't simply target errors by providers, but also focus on improving healthcare systems, design, and on enhancing the transfer of information between providers. Eliminating human error is impossible because we are human creatures. Instead, creating a safe system where human errors are anticipated and prevented should be the key. To Err is Human, the article suggests that mistakes can best be prevented by designing the health system at all levels to make it safer, to make it harder for people to do something wrong and easier for them to do it right. Several governmental and non-governmental bodies oversee patient safety issues for health institutions. The Affordable Care Act, for example, addressed some of the Institute of Medicine's suggestions about coordination for patient safety by mandating the creation of a national quality strategy. The Joint Commission releases a list of national patient safety goals every year, and the National Quality Forum lists 34 safe practices for better healthcare. Nobody can argue that a huge advance in medicine has occurred in the reduction of medications and pharmaceuticals, some of which can do amazing things. Some medicines that make people feel better, save lives, improve outcomes. Unfortunately, every medication also has risks, including toxicity, side effects, and interaction with other drugs. So medications are an important area of safety concern and a focus of quality improvement. In the hospital, about 5% of patients experience what's called an adverse drug event, or an ADE, and 10 to 15% experience a potential ADE, meaning no harm was caused by that error, but an error still occurred. Out of the hospital, nearly 25% of patients experienced an adverse drug effect, leading to about 70,000 ER visits and 100,000 hospitalizations each year. Traditionally, and it's always been blamed on and mocked upon physicians' bad handwriting that's led to medication errors. But that's not always been the case. If you see the chart on the side, keep in mind that the prescribing stage can include many pitfalls. The 8 rights of medication administrations are right patient, right medication, right dose, right route, right time, right documentation, right reason, and right response. Each one of those steps can be a chain in the link of an adverse drug reaction or event. And why do some of these reasons occur? Well, one of which can be something called polypharmacy. All of these ADAs occur in part because we take so many medications. About 30% of adults take 5 or more medications, which can get confusing, not just for the patient themselves, but for the participating providers who may not be following up with each other. And there are plenty of other reasons to make a mistake too. Some of the biggest risk factors for an ADE are age, either way old or very young, a long list of medications, as we said in polypharmacy, limited health literacy, and risky medications such as blood thinners. Another issue, as I've mentioned before, is poor follow-up. Patients discharged from a hospital with a whole list of medications and instructions, but no one to really go over uh, when to take which instructions or when to see a further follow-up provider. And just the workload demands of everybody involved, from physician to especially nurses, overlooking medications, overlooking dosages, overlooking schedules of when medication should be administered. So now, people get sick 24/7. In an ideal world, a provider who knows a patient would be available anytime, anywhere for any type of care and would treat the patient until he or she is well again. Well, that might happen on the Star Trek Enterprise when you have one physician taking care of a whole population, but doesn't really happen in the real world. Unfortunately, physicians and nurses have to sleep too, so patients will inevitably have their care transferred from provider to provider, nurse to nurse, and system to system. Anytime the care of a patient changes hands, there's a risk of necessary information falling through the cracks. The AHRQ compares transitions to a game of telephone. I'm sure everybody's played telephone at some point in time in their life as kids. You know, you line up, you whisper a little secret into one person's ear, and then they whisper it into the next person's ear, and so on and so on. And the fun thing about the game is to see how distorted the message gets at the end of the chain. Well, that's not so much fun in medicine. It's rather dangerous, considering that an estimated 80% of serious medical errors involve miscommunication between caregivers when patients are transferred or handed off. Here we'll discuss the two foci as transitions. First, transferring patient transferring care of an inpatient called a handoff or a sign out, and second, transferring a patient from the inpatient setting to the outpatient world called disposition. When we talk about handoffs, this topic heated up to 2003 when the Accreditation Council for Graduate Medical Education implemented resident work hour restrictions, effectively increasing the number of handoffs. Subsequent known study found that any given patient experienced about 15 handoffs during a 5-day hospitalization. 8-hour shifts in 15 days times 5, yeah, the math makes sense. And resident physician participated in 300 handoffs during a month-long rotation period. A good handoff will let the new provider know how sick the patient is, active medical problems and treatments, and issues that might develop. Some of the major problems with improving handoffs are: A, most providers receive little or no education about how to perform handoffs. B, there's no real accepted standard for what handoffs should look like. And C, most handoffs take place rapidly in a noisy environment. Different handoff mnemonics have been suggested, such as SBAR or IPASS in pediatrics, but none have been fully taken root in the medical literature. Research looking at handoff improvement, including standardization, has shown mixed evidence in terms of improving patient outcomes. Through a large study in 2013 indicated a reduction in medical errors. Regardless, many efforts are being made to improve handoffs. In the meantime, the danger of increased handoffs is a trade-off for reducing work hours. One area of focus is making sure patients leave the hospital on the correct medications, called medication reconciliation. Healthcare providers in the hospital often don't have access to patients' outpatient medication lists. And while hospitalized, a number of different medications are started, stopped, and modified. Even in hospitals with advanced electronic systems, keeping track of these medications changes can be tricky. Research has uncovered evidence of discrepancies in medication lists in about 1/3 of hospital admissions and 14% of hospital discharges. As you can imagine, patients who are mistakenly taking the wrong medicines will often have poor health outcomes. In 2005, the Joint Commission named medication reconciliation a national patient safety goal, requiring hospitals to implement a standard review process of medication at admission, transfer, and discharge. They have since highlighted these processes when evaluating hospitals, though there is no gold standard for medication reconciliation that is used across the nation. Medication reconciliation is relatively low-hanging fruit for quality improvement. Improving the entire transition of care is a lot more difficult, in part because it's clear the process must rely on teamwork among providers and systems that must work together in new ways. Residency work hours has been a hotly debated topic for decades. Work hours for resident physicians have long been controversial. Historically, residents lived in the hospital and worked up to 120 hours per week, quite a bit more than a typical 40. Aside from these kinds of hours being difficult psychologically, research has shown that overworked, fatigued residents make more mistakes. Driving up medical error rate. Amid such criticism, in 2003, the ACGME limited residency work hours for all programs to 80 hours per week. In addition, as of July 2011, shifts for first-year residents, also called interns, are limited to 16 hours. Second years may go beyond and may be scheduled for a 28-hour shift. Few on either side of this issue consider this to be a satisfactory conclusion. The debate goes back and forth between pros of more hours versus cons versus more hours. Just an example of one of each. Someone who may be in favor of more hours may say that the more hours you spend in the hospital, the more you learn. Residency is an intense training period, but by necessity, should not be diluted. A counterpoint to that argument would be that it's inhumane for physicians psychologically, physiologically, and emotionally to drive off potential physicians from entering the field. The Joint Commission has also spent a lot of time and resources in research and developing protocols to prevent what we call never events. Never events are sometimes also called sentinel events, and it's somewhat of a misnomer. It refers to an adverse health event and medical error that are never supposed to happen to patients receiving care in hospitals and other healthcare facilities. Examples would be surgery on the wrong body part, stage 3 or 4 pressure ulcers acquired after admission, injury resulting from misuse or malfunction of a device used in patient care. These are just a few examples. Not all adverse events are preventable, and not all of them are going to be a big deal. It's not fun to feel nauseous after general anesthesia wears off, but it won't ruin your life. Some errors, though, are both catastrophic for patients and are easily preventable. This is why they are called never events. If you've read the media within the last couple of years, you may have read the story about the nurse in Nashville who overrode a secure medication dispensary cart's security code and delivered an inappropriate medication to a patient. This medication was supposed to sedate the patient. Instead, it paralyzed the patient to the point where the patient could not breathe, and the patient subsequently died as a result of asphyxiation. It was a horrible error. It was an irresponsible error. It was an error that was leveled on several causes, not just the nurse, but the system itself, such as allowing the having the sheet machine being allowed to allow one person to override its security code. But in any event, it led to the demise of the patient. Now, not only was this such an egregious event that this nurse lost her job and her license, she had also been brought up and was convicted of criminal charges. I can't believe for any moment that she had any intention of harming this patient, but the lawyers for the opposing family had brought up enough evidence that there was such amount of gross negligence on the part of all parties that this constituted involuntary manslaughter. And the hospitals had the big bucks to pay for the big lawyers. This nurse did not. She was the scapegoat, so she was ultimately the one that fell through the cracks. So that's why you can see how we in healthcare never want something like this to happen. And if you can see here, this is just a chart of the number of different types of never events that have occurred over the years in categories such as wrong site surgery, retained foreign object post procedures. I would usually find that to be more common than not. Misplaced nasal or orogastric tubes. Probably some of the most common never event that I've seen in my field were intubation tubes that were put in the esophagus rather than tracheas, central venous lines that were put in arteries instead of veins, things of that sort, and wrongly prepared injectable medications. But again, any of these things can happen. Another event I've seen over the years are persons who've been sedated and paralyzed for surgical procedures or pre-surgical procedures where the sedation wears off, but the paralytic has not. So the patient wakes up in the middle of the surgery, unable to breathe, feeling every single cut and scalpel that's going into their body, which is a truly horrific situation. It has happened. This is stuff we don't want happening in medicine. And so healthcare associated infections have also become a nationwide problem, leading to more difficult to treat infections. Healthcare-associated infections, HAIs, or more commonly known as nosocomial infections, so you may hear that term a lot in your further classes. They're diseases that result from hospital treatment or hospital overtreatment or overstay. They're infectious conditions that arise due to their care that their patients receive. Obviously, this is a reverse of how things are supposed to be, yet healthcare-associated infections are all too prevalent. The most recent analysis from the Center for Disease Control and Prevention estimated that a total number of nosocomial infections for the year 2011 was over 700,000, and about 75,000 patients with these type of infections died during the hospital stay. This means that 1 in 25 hospitalized patients gets a hospital-acquired infection, which are usually more resistant to antibiotics than typical infections and therefore tougher to treat. That wasn't bad enough, they're also expensive. Another CDC report calculated that HAIs cost hospitals between 35 and 45 billion per year. In an effort to improve quality and lower costs, Medicare has not reimbursed hospitals for any care related to certain hospital-acquired infections, including catheter-associated urinary tract infections and surgical site infections after certain elective surgeries. Elective surgeries, not necessarily emergency surgeries. And during emergency surgeries, sometimes you don't have the ability to scrub and cleanse as efficiently as you wanted to. Since 2008, another initiative seeks to make healthcare-associated infections transparent. Medicare publicly reports the rates of these infections, and many states require hospitals to report their rates. Both payment refusal and transparency are incentives for hospitals to prevent hospital-acquired infections. And once again, if you follow the news media for any time within the last couple of months, you'll notice the dominating stories of nursing strikes and nursing job actions. And really to bring light to the importance of nursing and proper nursing staffage and proper nursing training. This has been a big issue in the development or lack of development of healthcare. I mean, what about nurses? Nurses do most of the heavy lifting while doctors get all the glory. They have an enormous impact on quality of care. And the nursing shortage has been known as a national disaster. Nurse-to-patient ratios have been definitively proven to either improve or reduce quality in patient care. Nurses are usually the providers who have the most direct contact with patients, and they perform the bulk of the care. They place IVs, they administer medications, they diagnose pressure ulcers, they place urinary catheters, they connect cardiac monitors, they monitor vital signs, they put patients on fall risk precautions. There's sentinels to see if patients' care or their health status is going in the wrong direction. You can see the list goes on. As you might imagine, the nurse has an enormous impact on the overall quality of care. One easy to understand measure is nurse-to-patient ratios. The evidence shows that the higher nurse staffing, independent of environment or disease, improves patient outcomes. But what does that mean? Higher nurses to patients means more money. For instance, one study showed that a hospital at capacity of 10% increase in the number of patients assigned to a nurse leads to a 28% increase in adverse events, such as infectious and medication errors. Fewer nurses with higher patient loads leads to more adverse events. It's not a difficult equation to crack. On the other hand, in another study, a 10% increase in nurses, RNs, was associated with a 9.5% decrease in the odds of patients developing pneumonia. More nurses lead to decreased adverse events. So improving nurse employment, job satisfaction, skill level, and work processes are all focus of quality initiatives and policy making. In particular, you can look at the National Quality Forum and the Joint Commission for Policy Prescriptions. So we're going to take it at that point in the textbook for this week's lesson. Just to go over some topics of important concern. Please reread the chapter and go over what definition of quality in healthcare refers to, the Donabidian triad, important definitions such as safety and adverse drug reactions, transition of care, know about the problems with handoffs and dispositions, the controversy of residency work hours, sentinel events, these called never events that should occur, and know some examples of that. Know the economical and social and healthcare issues with nosocomial infections, and please have an appreciation of the importance of nursing. Even though this presentation is not live, if you have any questions you'd like to bring up to the general forum, please feel free to do so. If you happen to stumble onto any YouTube video or news article that you feel may be pertinent to this week's subject material, please post them. You'll get points for participation. You'll also help enhance the value of this class. With that, have a great week, everybody.